The Bay Area Association of Kidney Patients presents Dr. Steve Katznelson, who will talk to us today about kidney transplantation with an emphasis on paired donor exchange. Dr. Katznelson is the medical director of the Kidney and Pancreas Transplant Program at California Pacific Medical Center, where he has developed the most active paired exchange program in the Bay Area.
So I am going to talk about pair donation in the second half of this lecture, but I want to get there by talking about living donation in general. If you'll go on, there are a couple of historical points that are just out of interest. I think another hit of the slide. So kidney transplantation goes back over 50 years now, and it all started really in the early 1900s when people started to understand a little bit about how immunology worked. But the first transplants actually happened in the early 1950s. This guy named Marius R. was a carpenter who didn't exactly follow his trade too well. He had a ladder that didn't work, and apparently it fell over. He impaled himself on a wall and went to the hospital with what ended up being a kidney rupture. His mom, this was Christmas Eve, I should add. His mom showed up and made the very brave offer to donate a kidney to him. She did that. And the kidney actually worked for a while. He was in kidney failure. Actually, he had ruptured the one kidney, that had to be removed. The other one was damaged badly enough that he had no kidney function of note. And the kidney worked for a while, but then it failed because at that point in time, no one had really figured out the immune system to develop anti-rejection medications and the like. Next, please. But it spawned a great deal of interest in living donation. Thanks. And in both in the United States, mostly centered on the East Coast around Boston, and in Paris, a number of clinicians and scientists were working towards living donation and making that work with different techniques. But that spawned a number of medical and ethical issues that I'll speak to some degree about in a few moments. The main ethical issue actually had to do with the fact that till that time, and I should say this is an issue that comes up still, there really had never been any surgery done on healthy people. I mean, when you think about it, a living donor is someone who, by definition, is completely healthy and undergoing surgery in a way that in no way medically benefits them. And so the concern was that you take a kidney out of a healthy person, what are going to be the ramifications down the road? And they looked to data like this that was quite interesting that came out of World War II. The yellow line up on the left there were soldiers in World War II who ended up having a one-sided kidney removal, a unilateral nephrectomy, for trauma that was sustained on the battlefield where there really were no other injuries. And horribly, and surprisingly to me, that was the numbers of tens of thousands of people had that type of injury. And so these people had their kidneys out, and the control population in this study that came out in the 50s were people who were age-matched and otherwise demographically similar who had two kidneys. And basically what you see here, looking at survival curves, was that having a kidney out didn't affect long-term survival when you compare them to otherwise matched individuals. So the bottom line here was you can remove a kidney from someone and they live a normal lifespan. Next, please. So in the mid to late 50s is when living donation really started to take off. And the best case scenario is when a recipient has a perfectly matched or identical twin. In the case of the identical twin transplant, as was the first successful kidney transplant that happened in Boston in the mid-50s, a kidney can be taken out of someone, this twin with a smirk, and the recipient, the twin with a smile, and you can actually do that transplant without any immunosuppression because they are genetically equal. I've been involved in 2 of those transplants in my career so far, and it's really amazing. The transplant's done, the recipients go home without any anti-rejection medication. Certainly from their kidney disease and other problems, may have a blood pressure pill or whatnot, but the kidneys tend to last a lifetime and do quite well. Next. Here's another group that came just a bit after, and I haven't yet figured out who was a donor and who was a recipient. These are 2 twin sisters and all their kids. All of the kids, by the way, were had after the transplants, both to the recipient and to the donor. Next. But of course, we're not all blessed with identical twins, and so it came to the scientists to try to figure out how to do these transplants, even though people were not genetically equal. And so this young lady who was a recipient, and this her brother-in-law, so a living, as we would call now, a living unrelated donor, underwent transplant together. And they were not matched, of course, at least not completely matched, because they're not identically twins. And the kidney actually worked for a while under the treatment with immunosuppression of the day, which horrifyingly to any of those of you who have received kidney transplants already included up to 20 grams. That's 20,000 milligrams of steroids, boatloads of Imuran and radiotherapy and radiation therapy. That kidney actually worked for quite a long time, and they were actually able to treat rejections using those therapies, which laid a lot of hope for people down the road that this could work. Next, please. So through time then, there have been a number of different barriers that have gotten between patients and transplants. Certainly immunosuppression has gotten better over the years and allowed for increasing survivals, as I'll show you in a moment or two. But also there have been new surgical procedures that have made it easier for donors to donate and make donors, frankly, want to donate more. Betsy, another slide, please. So this is a very old slide, but I use it because the story is still somewhat the same. This is a timeline of when most of the currently used anti-rejection medications came about. So in the 50s, there were only steroids, and then Imuran, azathioprine, came out. Some of the antibody medications that were used just after the transplant that were intravenous came out in the 70s and 80s, OKT3 being one of them. And finally, cyclosporin and some more modern immunosuppression, tacrolimus and Cellcept. So what this left us with are transplants that work better, but also it allowed us to use different medications when there were side effects that were truly affecting the transplant itself or patients' lives. Next. The ethical barriers to living donations were many. So there was not only the issue of what was termed mutilation of a healthy person in order to take the kidney out, and therefore violation of the kind of do no harm credo that we all sign up for in practicing medicine. But there was a concern about whether or not donors were altruistic and how to actually define altruism with respect to living donation. Some thought that the altruism that led people to living donation was radical and that people were a little mixed up in the head to do that, and it shouldn't be allowed for those reasons. And perhaps of greater interest more recently was the concern about paying for organs, which is illegal in the United States, to sell them, and it's actually illegal to coerce people into transplanting organs, which I'll talk more about later. Next. Does living donation actually help the donor in any way? Well, we'll talk more about the possible medical benefits, but there's been a lot of studies that have shown that there's probably a psychological benefit to donors. Some of it makes inherent sense. If your spouse needs a transplant, you give your spouse a transplant. There are several people in this audience who know well about this. Then not only does the recipient do better, but the lifestyle of the donor does better. But there is some concern as relationship between the donor and recipient becomes more separate. Not a brother, not a spouse, not a parent, but a friend or a church group, or someone you meet on the internet, that the farther away that relationship is, the less the benefit to the donor. And should we be thinking about that when we're discussing whether or not people make good living donor candidates? Next. So in order to address this issue to living donors, and I do this quite frequently when I'm interviewing living donors, I'll show a slide like this. This one came out of the Scandinavian literature about 10 years ago, and it tried to address the question in the more modern era, how do donors do with respect to longevity after they give up a kidney? These are living donors. And these look like insurance company survival curves. This is patient survival on the y-axis, and now 25 years out from donation on the x-axis. And they took donors, which is this line up here, and again compared them to other people who were demographically similar. And oddly, what they found is, if you believe the data, and the point the authors were trying to make, was that if you donate a kidney, you'll live longer. So somehow donation increased longevity. And this and subsequent data, I think, shows us that donors live the same lifespan that they were planned to. So donation does not change longevity in big populations. But donors do become kind of a special group because at a relatively young age, 30, 40, 50, the usual ages of living donors, they have a very, very thorough medical workup, the likes of which they probably wouldn't have had before, and hopefully are set on a course for good healthcare follow-up thereafter. And so the donors become somewhat of a selected group of people who are healthy and go forward with a healthy lifestyle after their donation. Next. So there have been a lot of questions as to how, I just talked about lifespan, but how medically do donors do after donation. And this is a bit of a busy slide, but I'll just point out the pertinence to you. This looked at people who donated and compared them to their siblings, brothers or sisters who did not donate. And it looked at kidney function via creatinine. This is 1.0 and in this study. And there were, I forget how many people, there were actually a large number of people in this study. And their post-op creatinines were 1.1 and compared it to siblings whose creatinines are 1.1, just suggesting again that donating a kidney didn't make you much different from matched people who did not donate a kidney. And looking at blood pressures too, actually, although there was an elevation in blood pressure after donation compared to pre-donation, it was not different than the siblings who did not donate. So, so basically long-term living donors do well. Next. The benefit, so to the donor, there is an equal lifespan, perhaps an improved quality of life to the donor. What does living donation do for the recipient? Well, many of you know this. I'm going to spend a few slides talking about the numbers these days, but there's clearly an improved outcome given large patient populations if you have a living donor kidney versus a deceased donor kidney. There's no waiting time, technically speaking. If you come to us with a living donor, we can facilitate an evaluation that'll leave patients transplanted within months rather than 4, 5, 6 years on a waiting list. And as I like to always tell donors when they're just post-op, when they're still leery, still wavering from all the anesthesia that they've had, I said, do you know you gave 2 kidneys? And they say, what? What did I sign up for? But in reality, people who donate a kidney actually do provide for 2 kidneys, because in giving a kidney to a recipient of a living donor transplant, you take that recipient off of the waiting list, and the kidney, the deceased donor kidney that was supposed to go to them gets to go to the next person. So it really is almost two for one. Next. There is additional benefits to living donation with respect to long-term transplant success. So if you look at living donor kidney transplant versus deceased donor transplant, living donor transplants do better. Living donor transplants offer an earlier transplant, and this slide is just to suggest that the longer you wait for a transplant, the poorer the long-term anticipated success. Next slide. Having said that, though, it is very clear these days that we can make people who have been on dialysis for 10 years have transplants that last for a lifetime. So although transplanting early is of benefit, it's not a necessity, because we can make all kidneys work well given current technology. The next few slides will just convince you, if you're not already, that there actually, can you go back one? That there are some benefits to living donor transplant. This is looking at 1 year, 2 years, 3, 4 years after transplant, and this is the survival of the transplant itself. In blue, living donor, in brown, deceased donor. So better early and late. Next. These are current data that patients often ask for with respect to what is the graft survival, comparing the two at 1 and 5 years. 94% for living donor average success at 1 year, 88% for deceased donor. And I put in brackets, we just published our own data at CPMC, and our data for the same graft survival is 99% at 1 year and 94% at 1 year for deceased donor, which is really, I think, fairly remarkable. Next. So we're asked to publish and talk about these 1 and 5 year data, and I think that was a lot more pertinent 10, 15, even 20 years ago when a deceased donor transplant was supposed to last 8 years. But now that we expect transplants to last a lot longer, we spend a lot more of our time not looking at 1 year, not looking at 5 years, but what are the transplants going to look like at 10 years, 20 years, 30 years, 40 years out from the transplant? And if you look at the national data, we expect transplants these days of a deceased donor that are done today, in this year, if it's a deceased donor transplant on the average to last 14 years, and a living donor to average to last 22 years. Yes, sir?
How much of the fact that a living donor kidney lasts so much longer is because the recipient probably did not have to wait as long on dialysis?
That's a great question, and in fact, this is all comers, so it doesn't stratify by that. So there are actually cross tables that you can look at to try to figure out, okay, I'm going to get a living donor kidney transplant. I'm a preemptive transplant. I've never been dialyzed, and my donor has these and this such and such quality. I have polycystic kidney disease, not diabetes, and you can actually look to find what to expect. For example, for a living donor transplant for someone who is relatively young who has polycystic kidney disease and has what am I missing here? Oh, and has not started dialysis. This number on the average goes up by 50%. So there are many factors that go into this, but the main factors that make the main other factors that make living donors better than deceased donors are the health of the living donor and the amount of time it takes from the time that the kidney is taken out of the deceased donor until put in the recipient. That quote-unquote cold ischemia time affects long-term success. A living donor transplant is implanted almost right away within an hour of the time it's taken out of the donor and going into the recipient. But the point you make is quite valid. There are many other factors that go into this number. Next. Back in the mid-90s, there started to be data published along these lines looking at differences between different types of living donors. This data is a bit old, and so, for example, this is the deceased donor success curve over, 12 years out from the transplant. This line is a lot higher now. As I mentioned, successes are better now for all transplants. But what I'm showing this to show you is that it looked, in the 80s and early 90s, we thought that you had to be a blood relative to donate a kidney as far as a living donation goes. But data from the mid-90s showed us that if you were a living donor, it didn't matter what the relationship was. You could be a blood relative, you could be a spouse, you could be a friend. It really didn't, not to say that spouses are not friends, didn't mean to separate that. You really have any relationship as long as you're a healthy living donor. So it really opened up the door for unrelated, mainly spouses, frankly, to donate. It opened up the door for friends, distant relatives to come forward as potential donors. The one caveat I would add that there is a subgroup of living donors, if we can identify that donor, who do better, and those, of course, the identical twins, which I mentioned already, but also 25% of siblings are perfect matches with their siblings. This is just the way the genetics falls out. So if we can identify a perfectly matched sibling, we will usually judge that person differently and try to direct them towards donation. Otherwise, it's not that we don't care, but it's harder to separate out spouses versus siblings versus parents versus offsprings as to who is the best donor. Any questions about that?
So what you're saying is that except for the case where you have a perfect antigen match, it does not matter how close the match is.
That's exactly what. That's also a good point. Is what I'm really saying is that the antigen matching, the importance of the antigen matching has gone down over time. Now, I don't have it. Actually, I probably do have it in another slideshow, but I don't have it in this slideshow. You can actually separate out kidney transplants by antigen matching, and you can show that a 3-match versus a 4-match has a 1% or 2% difference in success at 10 years out from the transplant. But it's not enough to make a call as to who's a better donor. To give you an example, if I had to choose a donor for myself and I had kidney failure, I would easily choose a friend who was a 0 match to me but was 30 years old versus my parent who was 70 years old, who is a very good match. So there's a lot of other factors other than matching that are more important than matching. This is just to show, based on, especially in the mid-90s, I mentioned to you when this data came out, that the unrelated transplants, spouses here in blue, and this red line here, are really I think one more hit on that slide, are really the greatest growth areas. And now, whereas about 10 years ago, about 10% of transplants were done from unrelated donors, now it's about 1/3 of all living donors are unrelated, including spouses and friends. So this is the area of greatest growth and one of the areas where we really push to have recipients look as far as potential donor candidates. Next. One of the other important things to note is, given all of these issues, living donation actually has increased. In 2002 was the first year where the number of living donors and the number of cadaver donors in the United States became equal. And since that time, the number of living donors have outspanned the number of deceased donors in this country. So I think we all look forward to a time where it's not 30 or 40% of all transplants are living donor transplants, but 50, 60, 70%. Next. As was mentioned earlier, there are 70-something thousand people on the kidney transplant waiting list. And the really unfortunate point, am I going to ruin Patrick by walking over there? The really unfortunate, just get your arm going. The really unfortunate point is that the difference between this line, which is the number of patients on the waiting list, and this line, which is the total transplants being done, is so vast and getting more and more vast. These are the people who are not transplanted who get stuck on waiting lists. Given everything I've said, although the living donor numbers in blue here are going up, it's just not enough. Next. So I'm going to now lead into talking a bit about paired exchange. Clearly, this data about living donation and the horror of the lengthening of the waiting list has led transplanters to look to ways to expand the living donor pool. I will mention and not talk about most of these. Certainly improved surgical techniques, I'll allude to that in a moment. Living unrelated donors I've talked about. Altruistic and Good Samaritan donors are the case where someone from the community just says, I want to donate a kidney. And not to anyone in particular, but just I know there's a need, I want to donate a kidney. I can speak more to that later if you like. But that is another way of expanding the donor pool. Frankly, that's not a huge resource, at least not to date. Internet matching, I'll talk more about in a moment. Kidneys from foreign countries and paired exchange, I'll talk about within a few slides. Next. So one of the surgical technologies that really has opened up living donation, as many of you have heard about, is this laparoscopic nephrectomy technique. This is my friend and colleague Bill Bree who's performing it, and you see that he has this trocar in his hand and a scope in his other hand, and he's looking up at a TV screen, and he's removing a donor kidney using laparoscopes. And the next slide is a depiction of that, where here's the human body. We don't decapitate, and our donors end up looking better than this. Here's the two kidneys and the bladder, and with a laparoscopic nephrectomy from the donor, 3 small centimeter-sized incisions are made, and the kidney is dissected out using these scopes, which are much like the arthroscopes that are used on shoulders and knees. And then the kidney is actually slid down while it's in the body and pulled out of a 3-inch incision that's about in the area of a C-section incision, just above the bladder. And it's really shortened hospital stays, and cosmetically is much nicer looking, and in part for these reasons, it's really enhanced the number of donors who have come forward to donate. Next. Internet matching, I could talk about that for an hour, but this is something that's new. There's actually a number of websites now. Matchingdonor.com is the one that's gotten the most press. Let's just say that thus far, UNOS certainly has not come out with a strong statement supporting this. There's a number of issues that come along with it. Next slide. First of all, there's a registration fee that is paid by the patients, which immediately makes it accessible to people who have that kind of extra money and not to others. Medicare, for example, doesn't pay for it. Transplant centers don't pay for it. It has been successful, matchingdonors.com, in transplanting some people. The first transplant, to make a long story short, there ended up being some major concerns that money exchanged hands for the kidney, which, as I mentioned earlier, is illegal in this country. It's not regulated thus far by UNOS, and therefore open to any one of a number of different issues. So many transplant centers, I mean, I don't condemn it, because if I were a recipient in need, I'd probably turn to any resources that I had. But it's not a universal answer. It's unfair to some and may be fraught with problems as it's unregulated. Next. Now, going to Asia and to other places to receive a transplant is a very, very difficult topic. Again, because recipients who want a transplant will do anything to get a transplant, will do anything and go anywhere in some cases. But the situation is fraught with difficulties. Both UNOS and the Transplant Society, to at least some degree, frown on it. Our transplant center has not yet come out with a statement, but will come out with a statement that we will not look after patients who go to China to get transplants there. And the reason for it is, as many of you have read or seen in the news, that these kidneys come from people who were executed in China. And let's just say the reasons for executions are not necessarily the reasons for executions that some of us might think are reasonable. We don't support that. We have 4 patients who were previously in our practice on our waiting list. They went to China without telling us, came back with a kidney. They've all been fraught with problems. All of them have had surgical complications. All of them have needed surgical intervention back with us. One of them I'll never forget, actually. He came back. He was Mandarin speaking, but his son, who's quite lovely, came to all the meetings. And the first time I examined him, he had the usual diagonal incision on his stomach. Then he had another one a little bit closer to his belly button. After a number of attempted translations, it turns out this guy was in the hospital for 6 weeks. Our average stay for a recipient is 5.5 days. It turns out that he had had a lot of belly pain after surgery, so about 4 weeks after the surgery, they got an x-ray that showed a surgical instrument retained in the belly, so they had to go in through this other incision. All the other patients have had problems with their kidney transplant artery, so it's not a reasonable fix for the problem. Next. As many of you know, there's a living donor evaluation process. I want to get into this because it's very germane as to how we run the paired donation program. We initially screen our donors for any sort of health issues that would make them not a good donor candidate. We then do some blood testing, and this is how the blood testing runs. For those of you who are donors who have had testing with us, I'm sorry, we draw 5 tubes of blood, and initially just do an ABO. Historically, just did an ABO blood type. If you were incompatible with your recipient, frankly, we'd throw the other tubes away because there was no other recourse for those donors. If you were ABO compatible, then we do a cross match, which is a test that I'm not going to describe, but is a test where we mix the donor recipient blood to see if there's compatibility. If it's incompatible, that kidney would reject quickly. So if the cross match was positive, meaning incompatible, we wouldn't go further. But if the ABO blood group was fine, the cross match was fine, then we would do the 6-antigen tissue typing. And after that, if things were compatible, then the patients would go for full evaluation. Next. So these are the ABO compatibilities between donor and recipient. There's the unfortunate O-type recipient that can only take blood type O donors, and the more fortunate AB recipient, though rarer blood type, that can receive a donated kidney from any blood type. Next. So the initial barriers to living donation for someone who wants to donate are historically that they have to be blood type compatible, cross-match compatible, then we do the tissue typing and go through the medical and psychosocial evaluation. Next. It turns out that about 1 in 2 donors who want to donate can't because they are either ABO incompatible, cross-match incompatible, or have something that comes up in their medical or psychosocial evaluation that makes them an impossible donor candidate. And to make the fortune even worse, for those loved ones or relatives or friends who want to donate to this person and can't, that recipient doesn't get any bonus points for having that person come forward. They end up waiting on the waiting list for a long time. Next. So thus the concept of paired donation came up to try to find a way to allow those living donors who wanted to donate to the recipients but couldn't for incompatibility to go ahead and donate anyway. So I present to you the easiest case of paired donation with a simple slide. And A and B here are, say, a donor and recipient. This person wants to donate to that person but can't. One more, Betsy. Because they're incompatible. And we find, but what the paired donation system does is find another pair that's also incompatible that cannot donate. Next slide. Actually, and matches them up as such. So it allows, hit it twice more, please. So in finding a swap or paired donation pairing, what we do is take this donor who wanted to donate to this person, and we find them a match with this recipient, and take this donor who wanted to donate to this person, and basically swap out or pair off the kidneys. Next. This is part of our educational brochure, and in fact, you'll find over on the side here, we have a couple of educational brochures. One, these are both kidney reviews. They're biannual that come out. One focuses on paired donation, the other one about older recipients. Feel free to take them as you're leaving. But this is what we use. Again, this person wants to donate to that but can't, and we find a similar pairing and allow the cross exchange. Next. So pair donation, it turns out, is very rare, and it's much too rare. As some of you know, there are just several programs in the country that offered pair donation. The technology behind it really was initially driven by Johns Hopkins, where they created a computer program that matched up the, I can't even tell you, but the large amount of immunologic data that comes with each patient, put all this data inside a pool, and the computer programming tried to run around and match up donors and recipients, as I've just shown you in the last slide. It turns out that because the main programs that offer this were in Baltimore and Ohio, it didn't make it very available to people on the West Coast, and people who could would go to Johns Hopkins or go to other places to try to enlist on their pair donation lists, just in order to have that option. Next. A couple years ago, one of our lovely patients, who happens to be the brother of someone in this audience, came to me after a successful transplant. David Jacobs had polycystic kidney disease and had a successful transplant with us. Here's his unrelated donor and one of his sons. And he had a vast history down here in Silicon Valley, starting up a number of companies. And I'm almost a tech zero, and I had heard of some of these companies, so that was pretty impressive to me. And he basically said he wanted to give back to the system. How could he give back? And identifying the need for better technology to run this kind of pair donation software and to create a West Coast program, I engaged David to help us create such software. And so he and a number of people he has hired subsequently have basically gone about the task of developing this brand new software. His company, Silverstone, the software is called Matchmaker, and it's the software that we're now using in our pair donation program. Next. The software, as I mentioned, the basics of it are, it takes living donor and recipient pairs who are incompatible and all their immunologic data, bless you, that made them incompatible, and puts them in a vast pool and tries to match them up with other donor-recipient pairs. If you think about it, and as I'll show you, if you put such people in a pool and aren't very careful about the pairs you choose to transplant, you may shortchange some people. And let me show it to you this way. This comes out of one of the authors at Johns Hopkins, Dori Segev, who with his wife actually put together their software. But let me explain this diagram to you briefly. These circles, 0 through 39, each one represents a donor and recipient pair who are incompatible with each other. So 28 might have been Patrick Barron and his wife who are incompatible with each other, and all these pairs are put into the software, and the software looks at all the immunological data and tries to find pairings. Each one of these lines is a pairing that the software identifies that could be a compatible pair donation transplant. If you don't think about it, or if the computer doesn't think about it well, and you do the wrong transplant, you lose a lot of people options, and I'll show you what that means. Let's just say that we took pairs 22 and 38 and went ahead and did that pair donation transplant. Well, it turns out the pairs 22 and 28 have a lot of different options, but by choosing that pairing and removing them from the system, look at all the pairings that are lost for other people here on the left. And so one of the bases for this software is not only to do transplants, but to do the right transplants in any population that allows for the most transplants in that population. The logic there is termed optimization. It's actually the same type of math that goes into the FAA's ability to land multiple planes at different airports at the same time, redirecting planes, optimizing the speed of the plane and the amount of traffic that can go through. So what we did basically is kind of recreate optimization math to best suit our population. Next. So to date, we have 185 pairs of patients that goes into our software. For a recipient who has, say, 3 donors who want to be involved in our program, each recipient donor is a pair. So if one person has 3 donors, in fact, they come into the software as 3 pairs. So the 185 pairs is not then 185 recipients, but about 110 recipients with an average of about 1.6 pairs per recipient. Excuse me, donors per recipient. We run our software, and I'm not going to get into it. I didn't bring my computer to show it off. It's actually it's my computer. I show that off, but the software built by David Jacobs and his coworkers. But the beauty of the software and why we're actually going to Richmond, Virginia in a couple weeks to UNOS, they've asked us to show us their software. It is so user-friendly. If you think of all the bells and whistles that come with gaming technology and all the products that come out of Silicon Valley, it is that technology that's applied to this medical need, whereas the other programs that are doing pair donation kind of have your routine, relatively simple quality software. This is software that I can run from my home, and I do 2 or 3 times a week, whereas the other software, because of its complexity, is run about every 2 or 3 months. And because of the rapidity with which I can run it, it creates more and more chances for everybody on the list. To date, we have that many pairs on the list. Last year, as we were just getting going last year, we did 3 double exchanges at our program and 1 triple swap. In the next 3 or 4 months, we already have actually, I think 5 now pair donations planned. Overall, we plan to increase our living donor yield by up to 20% using the software over the next year or 2. It takes a while to get up and going. There's a lot of infrastructure that it takes to manage these pairs, to follow these pairs, to get all the right information into the software, and frankly, to manage the software. This piece has been a very unexpected fallout from our pair donation program. And actually, I'm working on an article to send to one of the transplant journals on what I'm calling, for at least for the moment, the out of the woodwork effect. By engaging patients who thought they had no other possibilities because their donor was incompatible with them in living donation, we're spending a lot of time teaching them about pair donation and telling them about options. And so they're really, really getting it. And we did 4 transplants last year that were people who have an incompatible donor and then understood enough to start looking in their own personal community for good other donors and actually came up with directed donors, and we transplanted them this year. So I think in general terms, one of the kind of fallouts of education like this is that patients get more educated and can look to other different possibilities. Next. So we did the 3 double swaps last year and had the really great fortune to be involved in this landmark transplant with Johns Hopkins last year, involving your friend and our cameraman, Patrick Barron, and his wife. And frankly, what had happened was, and actually this was the subject of that Wall Street Journal article that was referred to a few moments ago. But what happened was we had identified, and I should say with the great help of Toby Gottheiner, 2 pairs of patients who were compatible with each other for a pair donation that was going to happen in our program. Because of the fact that one of our pairs had actually gone to Johns Hopkins to engage their pair donation program, Johns Hopkins found another pairing that could be involved in this exchange. And they gave us a call, and depends how close you read the Wall Street Journal article, but after a bit of disagreements on a couple of grounds, we ended up doing this triple pair donation that worked out as the following will show. So just one click at a time. So what ended up happening was this recipient back at Johns Hopkins was a patient who was doing very, very poorly on dialysis and had a very high antibody level. I'm not going to get into it further, but patients with high antibody levels tend to have very long waits on deceased donor waiting lists. So this lady was really out of luck and out of options. Because she so desperately needed a transplant, and understandably, our donors were not really interested in flying all the way to Baltimore to donate, her husband flew out to San Francisco and was involved in the following transplant. Hit it again. So we took her husband's kidney out and gave it to one of our recipients. That recipient's initially intended but incompatible donor's kidney, hit it again please, Betsy, came out and went to another one of our recipients. And then the Johns Hopkins team, the surgical team came out. We took out this donor's kidney. They put it on an airplane and flew it to Johns Hopkins, where they implanted it in their recipient within 10 hours thereafter. It was really an interesting couple days, and it was a very important transplant, mainly because these 3 people got transplanted. Yes?
How many hours, days did it take for you to coordinate all?
It took 30 hours in 1 day. It happened over about 6 weeks. Yeah, there were a lot of issues that had to be, including we had to go back and restudy the immunology for all these patients. So we had to do these cross matches between this pair, and that pair. That itself took 3 weeks while we were working on the logistics. But the main thing was that these 3 people got transplanted with cooperation between centers. But the other thing that happened was that for the first time, a living donor kidney was flown across the country. As we were talking about earlier, one of the great benefits to living donation was that the kidneys were put in immediately. And we, the transplant community, felt that that is something that was necessary for the kidneys to work well. Well, it turns out that some authors at Johns Hopkins had published several months before, based on some UNOS data of living donor kidneys that took a while to go into the recipient, that you could actually wait 2, 3, 4, up to 6 to 8 hours before putting in a living donor kidney, and it still worked the same. So what has come of this is that the real basis for a national sharing program for paired donation kidneys, where we could fly some of the kidneys, if not across country, at least to different destinations within the contiguous United States, would become a real possibility. So you won't read about many of these for a long while, but at least allowed for these transplants and further possibilities down the road. Matt.
Right now, each transplant center has its own list of pairs. You, for instance, have yours, and Hopkins has theirs, and there's not a lot of communication between you. So if there was a national program and a national list where there were more than 185 pairs, wouldn't the chances of finding more pairs be enhanced?
You're singing our song. We are, actually David and I are flying to UNOS in 2 weeks. We were invited to present our software to them because they are looking for software that a national program could be based upon. And they will choose one. It's one of 6 now, different programs that are out there, and then engage a national program. Now, that's the easy part. The hard part is organizing it, and as we've learned, in a single center, getting the infrastructure at each hospital together that can bear this load. UNOS is hoping for 2 or 3 years. Those of us who actually do this think it's going to take 5, maybe 7 years in order to do this, because not only are there communication issues, but for example, there's not even a single national standard for how to choose living donors. Every hospital has their own different policies. They're similar, and in some cases the same, but not all the same. Yes?
Do recipients find that they may get asked to consider accepting a slightly less advantageous kidney to help make the match work for more people?
No, well, not yet. How the national rules are going to go, in fact, Hopkins is much more pushy about that in trying to optimize their numbers, but we have to consider the needs of our donors and recipients, and there are a number of different ways to go about this, but we push nothing on the recipients. I'm involved now in preparing for what will probably be a triple exchange in April, where one of the recipients is 30. His 67-year-old, now 68-year-old mother was his incompatible donor, and her kidney is being matched up with a 50-year-old. So does the 50-year-old who put a 40-year-old kidney into the exchange? So does that 50-year-old who's putting a 40-year-old kidney in want to get a 68-year-old kidney? And the answer is, in his case, I think, yes. He has 99% antibody levels, and quite frankly, he's never going to get transplanted if not by this one. It was a needle in the haystack luck that we found a match for him. So, but in general terms, all the pairs that we've done so far have been equitable within about 10 years of age and size that there have been reasonable exchanges. And so each time we actually look at a pairing, the first thing we look at is Is there an age match? Is there a size match? Frankly, we would first go to someone, if there are many different possibilities, we would first go to someone who had a high antibody level because they may not have any other options. Back? I'm sorry, I didn't hear you. For an O positive recipient? Yeah, so the question is an O positive, being O positive, does that make it harder? In a sense it does, because the ABO options that you have are more limited. It turns out that the RH factor, which is a positive negative, you can throw out because it's not pertinent in transplant. It's very pertinent in blood transfusions, pregnancies, but we don't even look at it in transplant, so O positive is O. But yes, the options for O recipients are frankly quite a bit lower. Any other questions so far? Okay. So the difficulties of paired exchange in general is it's not a universal answer, although the Hopkins math suggests that if the pool is big enough that they might be able to find 30 or 40%, they might be able to transplant or find pairs for 30 to 40% in their pool. Our math shows us about 20 to 25%. So as I tell all of our patients involved, it doesn't guarantee a transplant, it just provides for another option. This is really not a difficulty, I shouldn't put it here, but it's taken a great amount of effort to educate a big population as to this, to get enough people interested to create a pool. And that's been a bit of a strain on our program. Strain on the hospital is the OR scheduling is horrendous. I first made a lot of enemies and then bought them the right Christmas gifts in the OR to schedule these things. But for triple exchange, that's actually 6 OR teams that are ready to go at one time, and it virtually eradicates any other elective surgery in the hospital at that time. And our program, as with many others, we mandate patient privacy so that if you're doing a triple exchange or you're doing double exchange, no one can meet each other unless everybody wants to meet each other after the transplant. So our hospital isn't that big, and so keeping people separate enough from each other has been quite a to-do. Next. I wanted to, before I end my talk, I wanted to address a question that had come up a little bit earlier about how would pair donation affect our area if it were implemented, at least on a relatively local basis. I am not a believer that a nationalized pair donation list is of the best benefit to the community. Between our list, which is about 2,000 strong, UCSF, the waiting list, UCSF and Stanford, there are about 5,000 or 6,000 patients on the San Francisco Peninsula, in the San Francisco Peninsula waiting lists who are awaiting transplants. Doing some simple math, you can put together a pair donation list of 500, 600, 700 just in our area. And so you can make a strong argument that pair donation shouldn't go nationally, but it should be mandated locally. And the easy transplants done locally, and for people who have high antibody levels who we can't find a match for, then those patients join a pair donation where they or their organs may need to be shipped. Yes?
Why is it that more of those 4,500 people you mentioned are not part of a paired donor exchange program? Many of them may not have willing donors, but how many are just unaware of donor exchange?
Well, I'd say that in our center, people are very aware of pair donation because we tell them from the get-go that this will be an option if you're incompatible. I can't speak for other centers yet, but since 1 in 2 donors are incompatible with the respective recipients, and most centers do about 30 or 40% of their transplants locally as pair donation, you can kind of extrapolate out the numbers we're talking about. If you do it another way and take, based on our waiting list, and that we're working very hard on this program, and that we're probably going to do 12 or 14 transplants by pair donation this next year. Our center contains about 11% of the regional waiting list, and if you extrapolate out further, then somewhere between 120 and 150 patients in our region 5, that's kind of the western United States, living donor transplants would be created every year by a program like this that's regional. So before we're not going to wait 6 or 7 years for UNOS to go about doing this. We're actually working at a regional level to implement a plan to at least get those transplants done while the national system is waiting. I actually don't think a national system serves this population very well. Next, I just want to go more. So here in brief is the big problem. This is not the kidney transplant waiting list, but the waiting list for all solid organs is closing in on 100,000. These are the number of deceased donors that are available. Next, and this is now, that's old, but go one more, please. And this is what's anticipated in the years to come. That within a few years, the solid organ, kidney, panc, liver, heart, lung, transplant waiting list will be 150,000 strong. So clearly, we're going to need to look at technology like this and other technologies to increase the possibilities of transplantation for those who do not have a living donor or who have a compatible living donor. Next.
Just a question for you.
Oh, I'm sorry.
It's okay.
Did you have a question?
Yes. Has there been any advancement in stem cell development to actually grow a new kidney?
Yeah. So that's a very good question. So the question for those of you in the back is, have there been many advances in stem cell transplants? And unfortunately, there has not. Although different tissue types can be grown, the kidney tissue itself is made out of a number of different cells that work in concert with each other, and there's been no successful whole solid organ kidney developed yet. That technology, along with the technology to xenograft, which is taking a transplant from a non-human mammal, was supposed to be ready by now, but the transplant meetings suggest that it's still a decade, 2, maybe even 3 off for a number of different issues. So that would be the best, frankly, if you could take your own stem cells from someone who had kidney disease, culture it in such a way and grow it in such a way that a new kidney grew. It's going to be possible, I think, but it's not going to be for a while.
How old can a person be to be considered for a transplant?
That's the other handout over here. The oldest growing group, sort of the largest growing group of transplant recipients is over the age of 65, if you look at the numbers. And there is absolutely zero in the way of upper ceiling to that. We do not care how old the patients are as long as they're healthy. In the last 3 years, we've transplanted 4 people who are over 80, and they're doing great. Those of you who are in dialysis units know that a 70-year-old who has a inherited type of kidney disease or any one of a number of different kidney diseases may be much more healthy than someone who's a lot younger than that with the ravages of diabetes or other problems. So we look much more at physiology than we do at the chronology that happens. It's just a number. So when we evaluate, the caveat though, and as mentioned in this article, is we know that patients over 65 have some different complications that have got to be screened for before the transplant in order to deem those people a safe recipient. But anybody should come to our clinic for an evaluation.
If you have an older kidney patient who is between 65 and 80 years old, having to wait 5 to 6 years for a kidney is going to be very risky. However, they may have a family member who is younger and willing to donate to somebody younger or somebody in need through a cross-match. That could allow 2 recipients to get a better age match. Is that possible now?
Yeah, so to date, so far, it's actually a very interesting question and one that we're kind of working on mathematically now. The real question is, can someone who has a compatible living donor enter a paired donation pool? Right. Because this is all incompatible. And so to better match age with age or weight with weight, but that is not being done. But I think something that should be looked into, because frankly, for example, if I was going to be giving my wife a kidney, and I could be assured that, and we're compatible, and I could be assured that if we went on a paired donation list, she was going to get a kidney that was about the same as mine as far as health goes, then I would enter a list like that. But with compatible donor-recipient pairs, they're currently not being put into these kind of lists, and maybe they should be. It should have not been done.
I'm noticing more and more new patients coming in are in the upper bracket.
Well, because of the increasing longevity of dialysis patients and transplant patients, and to a greater extent transplant patients, we would actually put a younger kidney into an older donor, to an older recipient. And there's no technically there's no age difference that we would not transplant, though we would have to think about it thoroughly. And where I thought you were going to go with this question, it's important to say that for people who are older, we think it is of great benefit to have a living donor, because you don't want to wait many years, because if you're 70 and you're healthy, you may not be as healthy when you're 73 or 75 or 76. But for older recipients, though, it's not a 5 or 6 year waiting time. You know, there is this extended criteria donor, or ECD, waiting list, and that's about half as long. At our center, it's about 2.5 years on the average. So we encourage all older recipients anyway to go into that list, not the regular list. Yes?
Would you clarify when the initiation of evaluation of a donor can take place relative to the recipient status?
Sure. So if one has a, everybody hear that question? We have to do the timing of a living donor evaluation. And if one has a compatible living donor, that means that the recipient's blood has been drawn, the donor's blood has subsequently been drawn, and about 3 or 4 weeks worth of testing is done to show that they're compatible. Once they're shown to be compatible, we can embark on a living donor workup immediately. And in fact, in the cases where, say, the recipient is almost going to start dialysis and doesn't want to start dialysis, I mean, we'll push those through in a matter of weeks. The unfortunate reality is, though, that there are often health problems for the recipients that are being solved before they can be transplanted. For example, the recipient who has bad coronary artery disease and needs to have a bypass procedure. In that case, we may delay the donor workup to some degree, just to make sure that the recipient can, in fact, go forward with receiving a kidney and are healthy enough to do that. But in general terms, once people are compatible, there's usually a reason to move quickly, not slowly.
Does the recipient officially have to be on the waiting list before you even begin evaluation of the donor?
By UNOS policy, they have to be on a waiting list. They technically don't need to be on the center's waiting list, but they have to be on a waiting list. There was a question back.
Rather than having people come out of the woodwork to get evaluated before they learn about paired donor exchange, isn't there some way you can advertise the program to people on the waiting list?
Well, we do send out things like this to broad populations. We sent a letter out when the program started, and then actually the hard thing is going backwards to people who are already on the waiting list and trying to get them educated too. One of the hard things is, and people don't really, we're often not given enough credit for this, is that it's a laborious task. I often take an hour on the phone to talk to one family, or if they live in Reno, or if they come in, it takes a long time, because it's tough stuff for people who haven't been presented this before. And most hospitals don't have the resources. In fact, including some local hospitals, and certainly some other transplant centers in our region, the main impediment to them getting started is their hospitals not supporting the paired donation program. Luckily, Cal Pacific really listened to us, and within the first few months, I was able to hire a nurse and 2 administrative staff to help me on this project, because I knew I couldn't do it. I'm a full-time clinician. But most hospitals are not supporting that. But in general terms, what you say is the best. You take a broad population, educate the whole group, and then you start having people come forward and saying, hey, I've identified this person, or yes, I want to be involved in a list like that.
I guess I'm a bit surprised that from 5,000 to 6,000 people on the list, only 500 of them have been found eligible for paired exchange.
Well, there are 2,000 people in our waiting list, and so we have 110 people so far, and most of those have been going forward since we started doing this about 1.5 years ago. So it's actually it sounds really small, but proportionally it's actually the biggest paired donation list in the country, and this is a problem with to a great degree a problem of education.